Beautiful statement.
Yes.
I love it.
Oh, hello. I'm pediatric cardiologist from the Severance Hospital. I didn't know that I should speak in English, so some things are in Korean, and it's long time since I speak in English, like more than 10 years ago. So bear with me today, and I will explain you about pediatric ECG, but actually ECG is not in there. So many things I want to tell you about the physiologic difference between pediatric and adult. And it's the very first page of the pediatric textbook. The child is not a little man. So, and I will speak about the growth and structure difference and compare the ECG changes and overview and reference values for the ages, and neonatal and infant are very different from adult. So I will speak about that. Then later on, I will speak about the children and adolescents. And congenital heart disease conduction system is quite different from the normal. So first, cardiovascular growth is very different. So somatic growth is actually peak at 2 to 4, and puberty, so it's 12 to 16. When in heart aspect, age 2 and 10, and puberty is the peak growth. And heart rate is very high compared to adult. And for just a quick funny information, we can do bypass surgery at least 1.3 kilos, and we did it like a few months ago. And central VA ECMO, 2 kilos, more than 2 kilos, we can do ECMO circulation. And peripheral bypass, vascular bypass surgery can be done after puberty because the vascular growth is very still going on later on the adolescent age. So even if the weight is same as adult, we cannot do the peripheral vascular bypass surgery. And as a pediatrician, we all use G-score to everything. So we do the calculation from the internet calculator, pediatric G website, or Boston Children's Hospital G-score calculator. And physiology changes after birth is really dynamic. Fetal circulation, the baby is actually not breathe. Baby can be supplies the oxygen from the placenta, and baby actually breathe in air after birth. So many dynamic changes can occur, and pulmonary vascular resistance is really high in So because the lung is not actually working in fetal circulation, and after birth, the day 1, the pulmonary vascular resistance can go in half as of aortic pressure, and it became slowed down until normalized till after 6 weeks. And premature babies has a really weak and undeveloped lung, so it's more slowly decreased. And LV-RV ratio is at birth, it's 1.8 to 1, and it became similar as adult as 6 months old. And ECG's normal range is very diverse. And actually getting the EKG from the pediatric patients is really, really hard. And the textbook of pediatric EKG, the first page, it says you need sedation to get the EKG, because infant and neonate is really crying even if the one sticker is on, and it has thin chest wall, so ventricular hypertrophy is quite hard to diagnose from the pediatric EKG. And heart rate from the day 1 to 1 month, it increases, and after 3 months, it goes slowly down. And think about the cardiac index. It's almost same as adult, and stroke volume is very low. So it's compensation mechanism to increase the heart rate to maintain the cardiac index. And QRS axis is first week it's 135 degree, and 3 to 6 months it's 60 degree. And PR interval it's 3 months old. After 3 months old, it increases because heart rate decreases. And QRS duration goes in QRS duration increases as the aging because the ventricular muscle is but ventricular muscle mass is growing, and Q wave is going decreases as the age goes up. And so ventricular hypertrophy we can diagnose with the Z-score. So it's more than 98% in R wave in V1, or S wave in V5-6 is more than 98%. And the ratio is same as adult R and S. R to S in V1 is more than 1. And LVH is R in V6, S in V1 is 98%. And biventricular hypertrophy is almost same. And the normal values in pediatric studies, it's cut, it is cut. So more, it's 2,000 pediatric patients. So it's not really huge number. So it can be not really correct, but we cannot really do the study with the large population in pediatrics. So remember age 10 is the growth spurt. So the heart rate it goes down abruptly, and age 10 it's almost normal as adult. And max heart rate is 220 minus age. It's easy to remember. And PR interval by heart rate is very diverse, and WP excitation criteria is under age 3 is 0.08 second, and more than 16 years old is 0.12. And I will skip all the and Holter, it's recent data 2025, and more about 4,000 participants, the healthy ones. Neonate PAC is more 22%. There are more than one PAC is normal, and it increased to 50% in adolescents. And PVC is prevalence is 10% in neonate and increases to 29%. I will talk about this later on. And normal range you can just look up. Arrhythmia symptoms and signs is really different from adult. Failure to thrive, weight gain is not really weight is not changing. It's failure to thrive, and actually symptoms are non-specific, and mostly arrhythmia can happen in decreased general condition, infection, fever, and etc. And congenital arrhythmia and post-surgical and catheter related. And in pediatric patients, we use even one French catheter, central catheter, as you see in this X-ray. It's the linear line here. It's one French catheter in RA in 700 gram. This baby can have SVT due to catheter related thing in RA, and even we do cardioversion in this kind of little baby, put to the lateral position and the cardioversion. And epidemiology in pediatric patient is sinus tachycardia is most common, and in neonate AVRT is most common. Infant is same, and child is almost same. And tachycardia in neonates infants, the definition is 180 beats per minute. It's really high. And most cause is stress. And in neonates, we use caffeine as a medication for the apnea, and it's mostly because of the caffeine use. We have tachycardia in neonates, and SVT is most common, less than 2 years old, and re-entry is almost every pathway. And heart failure can occur after 24 hours because little ones safety margin is really narrow. And we do cardioversion and PVC. It's really important to remember the PVC in neonates or infants because PVC is a sign of myocarditis or decreased ventricular function. And we can detect PVC by auscultation. So meet the good pediatrician is important because auscultation is quite missed in physical exam these days. And PAC is benign. And avoid eye massage because retinal detachment can happen in neonates. So never do eye massage. And atrial flutter or atrial fibrillation, less common. And fetal arrhythmia, 1/3 is atrial flutter, but it disappears after the delivery. And accessory pathway mediated SVT, but when it converts to sinus rhythm, it's spontaneously resolution. So no need to ablate the infant. And esophageal atrial pacing is in other countries it's quite common, but in Korea, the arterial pacing in esophageal lead, we don't have it. In other hospital like Seoul National Hospital, they do use epicardial pacing lead to esophageal arterial pacing. And in other countries, 520 soft EP catheter can be used. And in this hospital, we use transcutaneous pacing. And VT or PFib is mostly internal, other regions other than cardiac. So, and I really want to mention, don't use verapamil till 2 years old age. The baby can die because after AV block, it cannot sinus rhythm cannot be achieved after use the verapamil because of the very narrow safety margin. So don't use verapamil. And SVT is most common, but there are very few studies to do the done these days. So 1 in 225,000 or 1 in 250. And WPW is very common in general population, also in children. And before 1 year old, there is one single SVT episode. So more than 90% can recur. And wait until 5 to 8 year old for risk assessment or weight till 15 kilogram. I will explain the reason of the body weight later. 15 kilogram is generally 4 to 6 years old. And some AET is 4 to 6% of SVTs, and more than 3 years old, the spontaneous remission is very rare, so do the ablation. And multifocal AT is quite common. 50% of multifocal AT is due to respiratory illness. So treat the respiratory illness first, then evaluate the ablation necessity. And less than 5 years is more common. And JET is really common after post-op. So congenital heart disease surgery, 6% has JET. And for me, it's more than 6% in my experience. And VT in children is really rare. And short episode of VT in healthy teenager is up to 3%, quite large. And spontaneous resolution of VT is till 1 year is 90%. So wait, don't do the EP study. And 1 to 15 years is 50%. So we do Holter, and if we find the VT, we use medication first and wait till the patient grows up. And right-sided VT resolution is 76%, left-sided VT is 37%. PAC and PVC in children is also mostly benign. PACs, children has more than 50% has PACs. And isolated is benign. Frequent differential diagnosis needed as like 80. And PVC is 40% of healthy children has PVC, and 30% burden ventricular dysfunction can happen. And structurally normal children is also benign. And ovulation. Children has of less than 20 kilos. The textbook recommend cryoovulation, and indication could be AP-mediated tachycardias only, because the cryoovulation is much less harmful to coronary arteries, and loss of electrical activation happens prior to the loss of viability of the tissue. And more than 20 kilos RF energy is recommended, and before do the ablation, coronary artery angiography is needed, because coronary artery within 2 to 3 millimeters, for example, posterior septal branch can be sacrificed during the RF ablation. And actually, coronary artery size for normal children is less than 2. So 4 millimeters of coronary artery is actually aneurysm in children. And ST change if one sacrificed the coronary artery, ST change did not occur until 100 seconds after RF application. And even if the persistent stenosis of involved artery happened, the ST change resolves spontaneously within minutes. So it's very difficult to know. So coronary angiography is really important to RF energy in children. So children and in adolescence, energy close to the arterial side of AB groove is can guarantee more safety. And 5 French catheter tip and low temperature mapping at 50 to 55 Celsius degree, and lower temperature set point at 60 Celsius degree at ablation lesion, and shorter duration, maximum 30 to 40 seconds. And bradycardia in children and adolescents. Sinus bradycardia is most common, and it's because physical conditioning or anorexia or acute infections. And sinus node dysfunction is very rare. And AV conduction disorders, myocardial infarction, inflammation, myocarditis, or post-cardiac surgery. This CT is Kawasaki disease patient, and actually in Korea, Kawasaki disease is very quite common. And coronary artery aneurysm is this giant coronary aneurysm quite rare, but if you meet the Kawasaki disease patient, close examination is needed. And bradycardia in children and adolescents, first degree AV block is 8% in normal children, and 2 to 1 AV block is very rare. And bundle branch block is RBBB is mostly because of cardiac surgery, and LBBB is very rare. And this segmental analysis, I really want to talk about this because of conduction system can differ in congenital heart disease. You actually met this SD once in your life. And S refers to atrium, D refers to ventricle, this third position is great arteries. And normal heart position is SDS, but it can happen in like TOF, also can be SDS. So normal position, S means situs solitus, and RA in right, LA in left. In situs inversions mean RA in left, LA in right. Situs ambiguous can be heterotaxy like RA, both LA. It's ambiguous. So first letter is atrium, SIA. And second letter is ventricle, D loop and L loop. And D loop is right hand morphology is normal, like inflow is your thumb, and outflow is your second finger, and septum can be your third finger. It's D loop. it calls. L loop is left hand morphology is L loop. So second letter can be D or L. And last letter, before we go to the last letter, gray arteries, I want to really mention about concordance or discordance. So RA-RB is concordance, RA-LB is discordance. So it's called D or L. And also the outflow tract, RV to pulmonary artery, LV to aorta is concordance, but if RV to aorta is disconcordance. And you may heard many times like single ventricle, but in pediatric aspect, there's no single ventricle. It must have, the heart must have a rudimentary ventricle always. And last letter, gray arteries, it can have SILD letter, and it's my quick summary, but it's not a textbook. So if you memorize, aorta is in the center, and pulmonary artery, like right up, is situs, and pulmonary artery this way is inverted, and left lower is LTGA, and right lower is DTGA. I'm talking about this in short axis view in echo. And arrhythmia in congenital heart disease, many things can happen. And AV node displacement or abnormal function and absence of AV node can happen. And one thing you need to remember is AV block can happen in CCTGA, congenitally corrected TGA. It increases 2% by year and 50% by 50 years. And CCTGA can be, this patient can walk into your room. Like CCTGA can be looks normal till 70 years old. So you may encounter CCTGA once in your life. And Epstein anomaly, AV accessory pathway is really common. And Epstein anomaly is also not diagnosed till adult. And CCTGA can also have AV accessory pathway and many letters. But one thing I want to mention is Fontan is mostly single ventricle physiology, and Fontan operation patients can have sinus node dysfunction and also atrial tachycardia. Fontan. So remember the Fontan patient can have atrial activity low and high at the same time. And TOF patient, tetralogy of Fallot, this patient can have monomorphic VT for about 15%. And in this Severance Hospital, Dr. does the VT induction study in adult TOF patients. So tachycardia and congenital heart disease, 50% of congenital heart disease, as they encounter SVT during their lifetime. And Fontan operation is done age of 2 to before 4. And after Fontan operation, atrial tachycardia can happen in 2 years, and later on, it increases the rate till later childhood. And VT is TOF and markedly increase after 45 years. And VT can happen in systemic RV patient also. And cyanotic heart disease can have will have sudden cardiac death. AV discordance can lead to pre-excitation syndrome, mostly accessory pathway associated with tricuspid valve. The his bond more closely to mitral valve and accessory pathway in tricuspid valve. And the accessory pathway is more likely to happen in right side and near to coronary sinus to posterior of RA. And bradycardia and congenital heart disease, congenital AV block and post-surgical AV block or synod node dysfunction. And synod node dysfunction can happen when operation is done to RA and you actually never meet the Glenn shunt, but remember that something happened to RA is Glenn shunt. So SVC to pulmonary artery and IVC is just leave. This state is Glenn shunt. And conduction system in congenital heart is ASD, VSD, many things, but I really want to emphasize the VSD and Epstein anomaly and CCTGA because one day you will meet. ASD secondum is not affect the location of conduction system, and common landmark changes only common landmark changes in ASD secondum, but there is a ASD primum. It's called partial AVSD, arterioventricular septal defect. It's completely different from secondum ASD. I will talk about it later. And VSD is most common congenital heart disease associated more than 50%, and VSD only is 20%. And membranous VSD, usually large VSD we repair in 1 month, within 1 month old, 1 month old, and the conduction track is inferior posterior to VSD. So when you meet the VSD repair patient, if it's perimembranous, the track is inferior posterior to VSD, and AV block is AV block risk is high compared to the inner muscular. It's inner muscular VSD. The track is anterior superior to VSD. So if the VSD repair patient inner muscular, you need to remember it's anterior superior. And AVSD, the physiology is VSD and AV is similar to VSD and AVSD, but the AV valve is like one body. So it's very different. And in AVSD, the AV node is posterior inferior to the defect and outside of the triangular core, and left fascicular branch originates relatively early from the common bundle, and that inferior basal AV is firstly activated, so left X deviation occurs. So if you your friend's baby or someone asks you, oh, my baby has EKG and something is wrong. So left axis deviation in neonate is really abnormal. So you need to remember left axis deviation in neonate can that implies ABSD. And Epstein anomaly is the track is almost normal, but Epstein anomaly because of the arterial RBBB pattern is normal among the Epstein anomaly patient is more than 71%, and absence of RBBB in Epstein patient with the subtle pre-excitation, it has in this you need to think about the accessory pathways there in Epstein patient, and 10 to 38% of Epstein patient has this kind of thing. And tricuspid arteria, maybe you never meet this patient. And there is no tricuspid valve, and it has only original posterior left vascular fiber, so it also has left exit deviation in neonates. And if you encounter the aortic valve surgery of tricuspid arteria patient, the AV node is near to aortic valve, so you need to carefully tell the surgeon AV block. You need to remember it. AV block can happen. And CCTGA, there's two AV node. One is dominant and one is non-function. And anterior AV node is usually dominant in usual atrial arrangement, and it goes up around the pulmonary artery and goes down. And if CCTG has VSD, it's anterior superior margin. And if the atrial arrangement is mirror image, posterior AV node is dominant and anterior AV node is not non-functioning. And DILB you may never meet, but it's similar to CCTGA. Yeah. And heterotaxy, right isomerism and left isomerism. Usual position is here, but mirror image, right atrium is in the right and sinus node. But if you meet the left isomerism patient, so a sinus node is hypoplastic or even absent. And bilateral right isomerism has two sinus nodes. And we can diagnose heterotaxy actually during the surgery, looking at the appendage morphology, but we can assume via CT, CAT scan, if the bronchus is in normal position or right isomerism or left isomerism. Actually, many things I want to talk about, but it's all I prepared. Thank you for listening. Is this
Wonderful presentation.
Yeah, it's great.
Especially the thing about the SDS in.
yeah.
It's mostly
I was
useful,
useful, yeah. I will
I
give
just
you
assumed, but yeah,
Yeah.
didn't know exactly.
everything is like screwed. It's just
Regarding SDS.
mm.
Can I just send the
Sure, sure.
SDS part of slide?
Yeah, yes.
I've already seen that kind of thing.
Yeah, it's important, right?
Actually, if you don't mind, can we share this is your presentation with the foreign fellows?
Yes,
You can send it to me, your file for me,
Yeah.
please.
yes.
I
I
know,
like the foreign fellows, Korean fellows.
everybody. So
Yeah.
I thank you, also your previous slide about your multiple actually presentation from Korean pediatrics. So thank you, appreciate that. I'm gonna get back to you still.
Okay,
I'm
thank you.
analyzing tracings. But certainly this will be a great educational value for not for the Korean fellows, but also foreign fellows we
Yes.
have. So we can share and they can learn, okay? Thank you so much. But there is an interesting paper that I recently read. Professor Igor Efimov lab raising question whether sinus node is not a single node formation. There's a paper published, I think in the Circulation Arrhythmia last year, looking at the human lung and the perfusion model. Maybe we have a sinus node also superior inferior node rather than one's common.
Oh,
So they're raising some significant sort of questions, many questions among many investigators. I think that yet to be clear. Second thing is about that the AV nodal conduction formation that you mentioned briefly, twin AV nodes. There is obviously many variations, Munkebrough heart and so on, but then they found the cases where you have a twin node, but they have one single common conduction system, like a Y shape. So they can manifest like almost AV node oriented tachycardia. Yeah, the case report now. So therefore, maybe human physiology, we have two separate AV node anterior posterior that as you grow, this merge become only one. So that partial migration would be common connection, complete separate would be twin AV nodes, and then normal would be one merging. So there's some question always coming up now. So obviously, evolutionary medicine people will tell us the story. And we find that Dr. Park and I were talking about not so long ago. Some patients, they have a double His bundle spike and have AV node reentry, very short PR. So that explanation could be partial merging of a posterior aspect of an AV node. One would be anterior posterior AV node, therefore facilitating reentry, only common His bundle sharing. Maybe that's why you have two double spike His bundle. Another theory that I read is that if you look at the paper by Robert Anderson published in 2016 or 17, if somebody one reference I can give to you. And they talk about when you do cadaveric study of human, AV node region is not condensated one single node like an adult in neonates. They are scattered still. So in other words, still merging, developing, progressing as we get older. Maybe that's explain why the PR interval also shorter. Because your conduction tissues are smaller. And then once you get merged, the PR get longer. Yeah, that maybe has the same thing as the sinus node. So we are already discussing this issue with him right now. Always Dr. Park always keep me more questions than actually what I have answers. So I keep looking. So that paper might be interesting to read. And also they talk about during the neonate, you have many other non-nodal connection, muscular connection, myocardial fiber between atrium and ventricle, but yet they're not functional. They don't behave like a pathway. And then adults, they get absorbed and disappear. So I think it is part of the evolution growth of human nature. So that's something that fellows need to understand, that way why the PR interval is shorter, P wave is smaller and so on. So those are, I think, important. Yeah, it's a great lecture. Thank you.
I appreciate your wonderful presentation. It was very helpful for the physicians. And I learned a lot. And as everybody knows, the Cerebras, the pediatric cardiology team is very strong. And thanks to Dr. take care of most of the pediatric arrhythmia patients. He made my life easier. But if I say that I recently learned from the International EP conference, so I totally follow patient is nowadays many people treat them by the percutaneous
Oh, yes, yeah.
Dr.
Yeah,
Trier is expert and worldwide famous doctor for that intervention. But the problem is after implanting the pulmonary valve, we cannot ablate those areas.
아, 네.
And as you know, that after successful surgery of Holy Follow, after 15 years and 20 years, most of people appears the ventricular tachycardia
Mhm.
risk of sudden death. But in United States and European doctors, before implanting the percutaneous pulmonary valve, they do the prophylactic beta
네,
ablation.
네.
And it is, I was surprised, it was remarkably reduced the BT episodes. In Korea, because of the insurance coverage issues, we cannot do that, but I think that is a
Right.
near future of our arrhythmia, the pathology of our patients. Thank you for nice lecture. Good morning.
Any other question?
몇 살부터 이바 있습니다. 애기들.
이들은 언제든지.
네. 그러면 지나면
Yeah,
다음 주에 그러면 홍 선생님이
so I'll share with you some interesting EKG that I learned from my, volunteer activities. I have I mean, I'm not gonna present all, there's many, but I will give one EKG in the morning for you guys to take some brain, exercise. And then I present a very simple case for the, fellows to think about. We just had recently a similar case like that in in Professor Ong had done. So it is a common sort of a clinical thinking. Before we become EP, we need to see a doctor. That is something that important. I want to remind you about it, Jeff. And then following that, for foreign fellows, or whoever Korean fellow wants to stay, I'm gonna discuss clinical EP. Lecture 1, so we're talking how to evaluate EP patient. When do you take to the lab? When do not take it to the lab? And then what I should be. And then I give you a case of, very first part of tachycardia ablation would be supravena cable tachycardia. Maybe give you a lecture about how to map, how to ablate those. Okay. And then we're gonna go down all the way to the LD. That would be a completion of your graduation before, hopefully. And then end of a graduate, before graduate, you're gonna say foreign fellow gonna have exam. After that phase, you study. Okay, not giving you all this for nothing, no.
I will make a top question.
It's not, let it be a mean guy, okay, we'll make a question, but I want. Okay, all right, thank you, have a good weekend. Okay. 슬라이드 저한테 보내주면
네.
할게요. 예, 그리고 그 케이스는
네.
저희가 그 디스플레이 해가지고 피드백 드릴게요. 네, 예, 감사합니다. 그리고 그 환자 아마 25일날 다시 돌아온다고
맞아요.
하니까,
네.
that may be useful for us before we back in.